As I arrived here this morning, Dr. Rosenthal and I were chatting, and we're talking about how relieved we were to be out of the country for a couple of days this week. And I really do want to begin with a little aside, and that is as I look at the slides this morning, and I look at the performance between the different countries, Europe, Canada, of course, the United States, and then I think about coming from the United States and titling a talk, The Search for Value. It makes sense to me to think that some of you would say, well, that's going to be a long search. Maybe I'll do my email. And what I'd like to say is that I think, and what I hope anyway, is as I talk with you this afternoon about some of the things we're doing and thinking about, you're going to recognize a common thread and a very common challenge that we all face as we go forward. I'm anticipating about 30, maybe up to 40 minutes of formal remarks, and then I'd like you to think about questions, but not just questions, feedback as well, because I'm pretty sure you're going to see we're all into this, what I think might be a crisis together. So, as I think about where healthcare is right now, and I reflect upon the conversations from Alberta, we just heard about it from the United Kingdom, we heard about it from Germany. The issue is the impact of our expenditures on healthcare resources, either upon our gross domestic product or upon our budgets, and at the same time, other resources that would support our delivery are going down. So looking at the impact of public expenditures as a percentage of gross domestic product, this is information from your own Canadian group, what you see is that the United States, it's at about 8.3, but Canada is about 8.1, and there's others that are even higher. So the burden of the healthcare resource use is probably common in the Western world, as we heard earlier today. In addition to the burden that is present, we also are hearing now about the inflation. And here is the trends just this last year from Hewitt in regard to the impact of inflation upon your budgets, both the USA general inflation as well as Canada and Europe, but then as you look at the medical cost trends, in an era of which resources are not going up like that, we all face a very common challenge. Now, I think that many times, at least in the provider side, in my own group, what we're running into is people that haven't been in the system to the point where they actually are taking the view towards this that it really must have. And that is, at least down in the States, a lot of folks, depending on how long they've been in the system, think that the change in healthcare is being driven by our Affordable Care Act, the new accountable care organizations, new care models that have come into place. The reality, of course, is that actually one of the problems in our country is the Affordable Care Act changed access to care, mandated access to care, mandated coverage, but we really didn't change the care model. Actually, the point of what the change drivers are isn't in the text, it's in the pictures. And I think if you look on your lower right, you might recognize the figure of Don Berwick. Don Berwick, previous head of IHI, very active up in all of North America, and of course of London as well, became the Secretary of Health and Human Services. Don Berwick, kind of a very eloquent but sometimes tart speaker, spent some time helping us understand that the quality and safety of healthcare was not what it needed to be. We knew Don quite well. He's been to Mayo Clinic several times in helping us and in speaking with us and studying us. And as he was presenting to the board when I was there, this goes back some time before he was CMS director, he was complimenting us really on some of our #1 quality rankings, some of the things that we were doing at Mayo. And he said, you know what? You're probably the best there is. You're the cream of the crap of America. And that was sobering. On the left are some folks, and when I say the names, you'll recognize them, but maybe not their pictures. That's Jack Wenberg and Elliot Fisher on the left. And their conversation, where Don's goes back about 20, 25 years, Jack Wenberg started a conversation about unacceptable variation in healthcare without any coherent connection to better outcomes, and his conversation goes back 25 to 30 years. So what I would submit to you, that what we're really talking about right now is the need to come to grips with a conversation that medical groups and government has been having for over 20 years about cost and quality of healthcare in America. And you just add it up, variable quality over high cost, that's low value. The American people, and maybe the Canadians, and maybe the Europeans do not think they're getting value for their money. And we need to do something about it. Now, our group, as we consider this, I think came to an understanding. As you just heard, I transitioned from my job as one of the chief executives of 4 CEOs of Mayo, I'll come back to that, to take the position for Mayo Clinic as Director of Policy and Payment Reform as a request of our trustees. What we realized internally at Mayo Clinic is we were, with more and more precision, defining the ideology of value, but we weren't defining how to put it into our system in a way that we could meet the needs of our patients and sustain the business. And I'm wondering, as I look at the challenges that I heard about in Alberta and others, have we really gotten to an understanding of how to do value-based care in a way that matches the resources available to provide that care? And are there opportunities there? So, while the ideology is good, when you get right down to it, what we need to adapt to is payment models that are aligned with value rather than volume and better outcomes for our patients. They all have common things, at least in our country. Every one of them transfers risk. They transfer risk to providers of care or others, and we're responsible for meeting performance goals and total cost goals, either with a capitation model or with a shared savings model or with a two-sided risk model, but they all transfer risk. The second thing they do, and perhaps more important, is they assign responsibility for a population of patients, and then they reimburse based on your performance. One of the problems we were having and are still having at Mayo is when we hear the word population of patients, we somehow start thinking about zip codes and large population groups of patients. But what if your population of patients is folks that need a knee replacement next week, and you're responsible for 90 days of their care? Or your population of patients is a number of very sick, dual eligible, our word, Medicare, Medicaid patients with chronic mental illness. If you're accountable for that, that changes everything. And value-based payment is how that accountability could be transferred. And we have to start thinking about population health in a much more granular way, and I'll talk to you about that. As I began my work, and I consider what is going to be necessary for my organization and other organizations in our environment to change, through a variety of things, this is my list. In my opinion, if these 5 things are not in place, you will fail to reform your healthcare system, period. Now, that's why I'm talking for feedback, all right? Just let me know if I'm wrong. But number 1, if you do not have a network of providers really serving the needs of the patient from ambulatory care through the hospital care, post-hospital care, and supporting their continuing needs, if that is not a network that is coherent, really kind of hard to meet patient needs. Just as important, they need to have an aligned purpose. If one group of providers' purpose is to prevent people from going into the hospital, and the other purpose of your system is to put people in the hospital to show economic sustainability, you're not going to be able to reform healthcare. If these first 2 things are in place, then you can coordinate the care model. But that will not work unless this entire system is supported by timely, actionable analytics, and then you can align the payment model. What we're doing is shifting responsibility between all these 5 things and saying we can't do it, rather than saying it is a responsibility of a group of adults to deal with this as a unified, integrated problem set and move on. So what about my organization? I think as I talk about Mayo Clinic, a lot of people think, there's Mayo Clinic. I think we've changed a lot in the last 10 to 20 years, and I'll just do a few minutes on that. So this is the mother house in Rochester, Minnesota. You look carefully, you can see the bronzes of William and Charles Mayo sitting there on the steps. And that's part of Mayo Clinic. It's the National Destination Medical Center. We also have activities and operations in Arizona, Florida, and throughout the Midwest, in what's called the Mayo Clinic health system. And this is the part that surprises people, I think. The Mayo Clinic does about 1.2 million unique patients a year. We care for, that's based on different registration numbers coming to somewhere in our system. About 620,000 of those patients are community and regional patients. And we must care for them and continue to support their needs over their continuum. This is the Mayo Clinic health system. That was what I was responsible for 6 years before I rotated out of that position into my current position. We deliver care in 70 locations located within 120 miles of Rochester, Minnesota. We have about 1,400 providers in this system, 16 hospitals, 70 care delivery sites. We own or employ this entire system, and it's salary-based. Within this entire model, however, our work and the work I think you're going to be engaging in as well is thinking about your organization in the new challenge of healthcare reform and trying to decide what it really is. We did this back in 2010, 2011, and trying to define the core business of Mayo Clinic. It was not putting people in hospital beds. It really wasn't even taking care of patients. The real core business of Mayo Clinic, and what we think is our core competency, is transferring knowledge to the delivery of better care with better outcomes. Knowledge to delivery. What that does, of course, is free you up for some really different models of care. So in addition to those physical connections that I just showed you, over the last 5 years, we've begun to develop the Mayo Clinic Care Network. It's an affiliate model because the financial model was not aligned, so it requires subscription. But we now actually have knowledge transfer between Mayo Clinic, our entire group, and affiliates at 45 locations in 30 states in the United States, as well as 4 foreign countries. We do e-consults, we share Mayo Clinic knowledge, we do tumor boards with them, we can provide stroke robots to support some of their rural emergency rooms, do EICU support, et cetera, et cetera. All because right now, our goal is to say 10 years from now when we say the word Mayo Clinic, you're not going to think of a place. And the ideal response could be 20 years from now, when a large number of people say, you know, I got really good care from Mayo Clinic, someday I might want to visit them. And start thinking about healthcare that way. Regardless of our plans, our fundamental purpose wasn't aligned. So what you can see here is we worked through all of the different statements of Mayo Clinic, the mission, the vision, et cetera. I won't read through them all. But what I did do is put in red the things that were added. And you get the idea that we cared a lot about integrated clinical practice, integrated knowledge, teamwork, and integrated model of care. And that is then our direction. However, there's an Achilles heel here. You've got it, we've got it. It has to do with cost. And what I'm going to do now is I'm going to show you a snapshot of something, and then I'm going to come back to it in much more detail in about 10 minutes. Many times when we were thinking of costs, we looked at it as a bell curve. What's the average cost and what goes on around it? We spent 30 years looking at unexpected variation in quality. So what you're looking here now is at the normalized cost per case for arguably complex patients. This is 10,000 cardiac surgery cases who got their care at Mayo Clinic between 2011 and 2014. And what we looked at was the variation from median cost, which is 1.0. You can see it there for half the patients. Now what you see here is actually a system that looks like it might be in control for between 75 and 90% of the patients. But for the top 10 to 15% of the patients, the variation from median cost is significantly higher. Now, we're going to come back and talk about how you might want to deal with that, but the reason I showed you this snapshot is to talk about now some national trends in which, if you think about it as variation, you might start being able to consider how we might deal with it differently. So here in the United States, there's your outliers. Let's look at healthcare expenditures. This is Kaiser Foundation. 5% of the people in the country spend 50% of the money on health care in America. Now, we, for political reasons, have a whole lot of issues in regard to how to pay for health care. But we haven't really concentrated, I don't think, enough on why do those 5% of people cost so much? And what can we do about it? Well, if you look at the number of chronic conditions, you see that about 14% of Medicare folks, anyway, have 6+ chronic conditions. We're spending over $32,000 a year on each one of those folks. And we're spending $2,000 a year to $5,000 a year on basically most of the population. Now, if I, as a care delivery system, wish to engage and help control costs in health care, the question I would have, placed to all of you, is a collaborative way to try to drive down the cost for everybody, or should we jointly try to figure out what's happening with people that have chronic disease and go where the money is? That's what we're trying to do. It has a huge impact on Canada. Here's the first slide from World Health Organization. If we do nothing about this, the projected deaths would increase by 15%. Deaths from diabetes increasing by 44%. Real human suffering. The costs? The cost of chronic disease in the country of Canada is 42% of your direct medical expenditures and probably 65% of your total indirect costs. $54.4 billion a year. Now, as I think about how we're going to control cost in the system, I'll talk about our system. Within the last year, Brent James from Intermountain, we know Brent pretty well. He's a pretty good statistician, very well known, probably known up here as well. So he and his colleagues have calculated, and Jack Wenberg calculated, and so-and-so and so-and-so calculated, that if you really look at the overall, quote, waste represented by care delivery that has no discernible impact on outcomes, or care delivery that was not requested by or necessary for the patient, such as ICU and a palliative care patient at the end of their life, fill in the blanks, about 30% of the cost. So for us, decreasing 30% of costs for healthcare in the United States would save about $1 trillion. Let's say we got together and over the next 10 years, we decided, you know, as a society, we probably could eliminate half of that. $500 billion is good, but we're not really getting at and approaching it because I don't think we fully understand it yet. Medicare is trying to help us, and I was just reading some of your things regarding the Plan 2.0 for Alberta. It looks like you're thinking about some shared savings models and other things as well. While it's a very difficult time in our country, I do think that alternate payment models will continue to go into place in our country due to the bipartisan support for that legislation called MACRA. And I think that these models will help us to learn, and there's also some significant parallels for you. The first thing in terms of the idea of moving towards comprehensive care is you have to have a comprehensive care system. And I'm showing this slide. It is from Mayo, as you can see on the lower left, in regard to how we think about surrounding our care system with teams. We've been team-based forever. And you can see virtual connected care as well as team-based care. But there's a flaw in this slide. And that's why I show it, is remind me of the flaw. The flaw here is looking at this from a care delivery system point of view rather than a patient population point of view. And you see the divisions between population health management, intermediate care, and complex care. And so often what we do is set up our hospital systems, our community systems, and our public health systems as separate entities meant to interact. The patients don't see it that way. I'm looking around the room here today. We all look like we're probably more into population health management, which is good. But life is just waiting to happen. Someone could need complex care in 5 minutes. Don't do that. I wouldn't be able to finish my talk. But this is a continuum. And our ability to impact the system is to keep people within our understanding and within our management system when they're moving through the parts of the system. Thus, your management of primary care and integrating that with your specialty care and integrating that with your hospital care is probably the best analytic system to manage cost. In addition to that, at least in our state, in our country, when people think of episodes of care, they keep talking about average patients. I don't think there are average patients. I think there is an average median patient. But if we don't understand the interactions, we will fail. So this is a complex slide just showing design and operational considerations. And what you see here is, if we're going to do this work, you need to understand type and level of risk. You need to say who's responsible for their care. And you have to be a little more expansive than saying it's a hospital or a primary care doctor, because patients are moving. And then you need to understand your patient population. If you consider any of these things as monolithic and non-dynamic, we're going to fail. And it's the relationships between these things we have to learn how to manage very differently. Now let's go back to this cost distribution of care, because this is where I'm going to spend probably the rest of my time. Not on this slide, but on this concept. So now we've got 10,000 cardiovascular surgery patients that Mayo Clinic is accountable for over time. By most definitions, if you're getting cardiac surgery, you're a complex patient, I think. That's fair. But what we see in this slide, based on our performance, is that we should, as a business, remember I'm talking about sustainable business, we should try to get a set price and bundle payment for those patients tomorrow, because they're in control. There's very little variation, if you will, from median cost. And we looks like from the slope of the curve, we're pretty good. The outliers are a problem, though. And in our system, if we don't understand them better, the risk is that folks who are trying to deliver episodes of care will try to identify them and deny them access to care, because obviously the costs would just swamp the reimbursement. So that's one point. The second point is, what's your competitive model here? So the competitive model is very likely in that variation for the 90% of patients. And perhaps that dotted line is a hypothetical line, because we don't have a benchmark against other cardiac surgery groups besides ourselves. But in another group, that could be readmissions, higher hospital costs, infection, error, et cetera, et cetera, et cetera. That's your competitive model. What it brings up then is you must deal with the outliers, because in my system, it might prevent them from getting access to care. In your system, it might bankrupt the system. And are we really understanding these folks and managing them as we should? Well, let's look at whether you can decrease variation. And what do medical groups look like? Now, this is obviously a flatter curve. It's elective, basically, total knee arthroplasties. Now we're looking at 7,000 Mayo Clinic patients between 2011 and 2014. Very little variation, just 12% variation for median cost. For 75% of the patients, just 26% variation for 90%. Well, what if you take another group? And again, it's different geographic areas, so these are normalized costs. But let's take another group. Work with them for a while and see what their curve looks like. This is about 1,000 patients from Dartmouth. Now, we worked with Dartmouth for a few years. We understand care models, et cetera. No need to show two curves. They go right on top of each other. So once again, in our view, there is a very different opportunity for the flat part of the curve, but the outliers are still not understood. I think you see negotiation and contract possibilities and lean management and all the other stuff we've done for years and years and years for quality improvement, working on the flat aspect of the curve. That probably could be done for the outliers as well. But the variation right now is so wide it confounds even the predictive ability of our group. That led to this. And this is going on right now. We'll get the first data out in 4 weeks. So let me explain to you what we're doing right now. And as I wrote in with my colleague from one of your data centers, he was nice enough to be sympathetic to me about where I lived, and I was really impressed with what he had going in terms of his access to data, but he didn't have, I don't believe, really good integration of inpatient-outpatient data. So we've got some common problems. Well, here's what we did. Mayo Clinic has very good data. We have it on about 5 to 7 million patients. It's clinical records. We have them over time. We've had it for years. CMS has pretty good billing data. They have records on 40 million patients for the CMS data set. So we went to them just about 13 months ago and said, we got an idea. If we do not develop an understanding of severity indicators and how to adjust claims based on risk, then this entire system of episode of care payment is at risk. And Patrick Conway, their chief medical officer, and their research team said, you're right. So we decided that what we would do is set up a data set that had 40 million lives in it from the Medicare set, and we'd add to it the 5 million patient records from Mayo Clinic. And we would look at the outliers together. And they would look at their perspective of the risk adjustment for the outlier population, and we'd look at our medical record view of that same group. We combined the data sets in a virtual data set, which went live in October, populated it, put in the rules, et cetera. The government side of it went down for 3.5 weeks over Christmas, which slowed us down a little bit. Maybe that sometimes happens here. Our systems go down too, gotta be fair. And that put us now about 4 weeks away from first delivery. What we're looking at now is the top 10% of patients that have lower joint replacement. And we're combining the billing records view of risk adjustment and risk with the clinical modifiers of risk. And we know prospectively that one of the modifiers of risk is whether you live alone, because you can't rehab at home if you live alone. Another one, of course, is obesity, et cetera. Really, when you think about it this way, then, the idea then is to engage collaboratively with CMS to inform new risk modifiers and use them to support value-based payments that recognize complex patients. The punchline for us right now is and we will find out more in another 4 weeks, is our initial work within the Center for Science Health Delivery says that this is going to be very difficult to do prospectively. That's the dream. But in our model of payment, we're going to get paid in an episode of care. At the end of a period of time, a year, there'll be a reconciliation date where risk adjustment, et cetera, is done, and then whether you meet total cost, quality, safety standards, et cetera, your payment's adjusted up or down. We think at that reconciliation date, high-value medical groups with appropriate information systems will now have a much better perspective, along with our payer colleagues, regarding the risks that lead to outlier status. And if it's expected variation, such as you have a patient on dialysis that gets a knee replaced, or someone with many comorbid conditions, we can adjust for that. Just as important as adjusting for that, we can perhaps normalize it. Would care by an integrated medical group for complex patients cost less for these type of patients having to wander around Manhattan trying to come up with a system? Probably, but we don't know. On the flip side of it is, if it's unexpected variation, infection, readmissions, falls, the other things, that's on us. That's a medical error. So you now end up with what we believe may be a rational, facilitative discussion about how to take better care of these folks and understand their costs in a more coherent way, and thus go forward as colleagues. What I'm talking about on the path to payment reform, at least in the States, is right there. A lot of the problem we're having in the United States right now is because we have physicians who are being told, just see 3 more patients a day. And we like that. See another couple. Just, keep them going. This is a productivity model for us. And our physicians are burning out. Oh, you're seeing enough patients? Make sure you're coding how sick they really are. Upcode that thing a little bit more, because then you're going to get paid more. What we really need to do is invest in the financial clinical analytics, matching a care delivery model to move to population health management in the terms in which I just described it with the appropriate granularity. Then we can move forward. So on my last slide, I guess, second to last slide here, it's what you see is now a fundamentally different relationship needing to be present within healthcare delivery to match this model. So remember, I started out with a network of providers, aligned purpose, coordinated care delivery, practice analytics, and financial alignment. What's that mean? It means system-wide teamwork, group process, interdisciplinary training, emotional intelligence, a willingness to understand the needs of others in the group, communications like we've never seen before, to understand with data our future. And that'll be informed by health service research, statistics we haven't even thought of yet, population health, and self-learning. So why hasn't it happened? Been talking about it, suffering from it, wondering about how it's going to maybe bankrupt us or wreck our business models for decades. Well, there's a lot of structural barriers. There's the inertial management and daily management challenges. When I was a CEO, I had, several issues a day and 1 or 2 real crises a week. Kind of hard to think about the future of American healthcare. The other thing is our past experience with contracts and payments not informed by appropriate data did not serve us well. And the previous impact in the model of non-data-based closed panel management of patients in the diverse country of America was met by resistance from the American people. It wasn't as well organized as Kaiser. It wasn't as data supported as Kaiser. It wasn't volunteered like Kaiser, and it just couldn't spread, and it imploded. I think it will come back, frankly, but we're going to need to do it a little differently and understand how to do it with at least nationally more grace and data. Mission and culture, providers right now, I go around Mayo Clinic, I've never seen them so agitated. I just think, take a deep breath. I'm in the hall yesterday, and in my current job, of course, I'm asked about 1,000 times what's going to happen to U.S. healthcare. I don't know. But I had people come up and say, well, I just hope we don't get into a nuclear war. Well, I do too. And so in the end, we must do this right, because this performance corridor for us is narrow. I think it's narrow for you too. If we move too fast and lose control of the system, we will end up wasting resources. If we move too slow, we won't serve our patients. It's a very narrow performance corridor. So just for this last image, where I'll leave you with, I've been working at Mayo now for over 30 years. Done a lot of different things, been a great career. I've loved every day of it. But now people are talking about the analogies like it's 1 foot on the dock and 1 foot in a canoe, and boy, a lot has changed. No, this is what it feels like to our doctors. But there's a couple of messages here. Message number one that I share with our doctors when I show them this is, this guy is not planning to die at the bottom of that. He's got protective equipment, looks like he's in control of his paddle. He's decided to do this. It might look crazy, but he's decided, I want to do this. We want to do this, and we've got to do this. And so I close with this for our group. I'll close with this for you. Jerry Garcia, somebody's got to do something. It's incredibly pathetic. It has to be us. Thank you. You want to do questions now?
See through and have a particular question. Well, thank you very much for a very inspiring talk. I'm sure we're going to think of different analogies about the going over the waterfall. But now I'd like to open up to any particular kind of questions that might have for Dr. Nesse. And as people might be thinking, I was wondering, because I know that the perception from a lot of people in dealing with the Mayo Health system is it's often very renowned in terms of cancer treatment, various things. And I was just wondering, and I believe you were a primary care physician, so I just wondered about how much of the integration of care between Mayo, the acute care, cancer delivery, and course of care, and how much is in continuing practice and dealing with primary care patients and follow-up to that care.
Yeah. So you're correct. We're well known as the as a place that does, I would say, rescue care or precision diagnostics care. But actually, most of our work the last 5 or 10 years has been working to integrate our system and try to deliver care closer to a patient's home. So with Mayo Clinic Care Network, et cetera, we're extending it so tumor boards are now available nationally. So someone from Chicago can send us work or e-consults. And just to let you know, 40% of the time, the consults for oncology patients do not need to be face-to-face. The information, the electronics, the ability to transfer slides, et cetera, is now advanced so much that you can do an e-tumor board without having to have physical presence of anybody. And we're trying to project that out. Within the community system, likewise, we'll go beyond cancer care. What we've done is, again, try to transfer expertise. So we have what we call EICU in that entire system in the Midwest that I talked about. The EICU system comes out of a central management center in Rochester, Minnesota, where actually staffed by our ICU nurses, they are able to keep eyes on 24/7 ICU cases out in the health system and assist when asked or monitor and pick up something and try to keep people closer to their home that need intense care versus sending them to Rochester. So my work was to integrate the systems, integrate the models, work on the analytics so we could follow these patients over that geography.
And just one other thing, I was wondering in terms of, are you, how much are you hit by the bundled payment impetus that's coming forward right now over the next few years? It started a few years ago, I think, with trials, and was Mayo, was it one of the pioneer trialers in bundled payments, or did you avoid it and now it's coming mandatory at you at this current point in time?
Yeah, it's a great question. I think for our destination center, we would call a bundled payment a center of excellence contract, in which you end up receiving cases, in our case, primarily from large employers like Walmart, et cetera, in order to deliver care to those folks with a guaranteed performance against standards. And so we have that now with Walmart and others for cancer, et cetera. An interesting part of that is when you looked at the value we offered in that system, surprising somewhat to us, but we have the national transplant contract for Walmart. So any of their employees that need transplants come to one of our centers. And our transplants weren't the cheapest transplant for the transplant itself. What we found is that, particularly for renal transplants, between 15 and 20% of the folks that were sent to us for renal transplant didn't need it. What they needed was much better management for chronic renal failure. Now, they might have needed that transplant, 2 years, 5 years, 10 years down the road, but they didn't need it then. And so from the expenditure spend point of a view, if somebody has a longer time horizon than a year, the Walmart folks said that was better than trying to wring 10% savings out of our line item costs for transplant.
Yeah, and just one quick question. In terms of your providers, are they salaried employees of Mayo?
Yes, the core employees of Mayo Clinic are all straight salary. It's based on national standards, so you just look at AMGA, group practice, North salaries, and we peg ours at the 70th percentile, and you could be the highest volume transplant surgeon at Mayo Clinic, but that's what you make.
Okay, and thanks, and we'll all be joining as a larger panel with everyone after the break, but if you could please join me in thanking Dr. Nesse for a great presentation.